Here we are again. Hi, everyone. It's so good to see you. And I know we have a lot of guests who are just joining, maybe your colleague or maybe somebody you know has sent this to you. And it's really our goal to connect more people in the area of myofunctional therapy and sciences. So we're really excited that we can offer this hour with Dr. Eyal Boetzer, whose work around the world has been both inspiring and very impactful. And his journey into tongue tie alone is something that I listen to often, because he talks about how he had no idea what tongue tie was. And this was in the early, I think it was 2000. And little by little, his interest and investigation as a pediatric dentist, and then looking at the functions around feeding, have led him to be even more impactful by doing missions in underserved areas and providing procedures. And so, Eyal, it's just so special that we can call you a friend and a colleague, and we've learned so much from you. And teaching in Tel Aviv under your assistance has been one of the highlights of my time in this area. So I want to say thank you. And everybody else, this is Dr. Eyal Boetzer, also known as Eyal. Welcome.
Thank you very much. Toda rabba.
Boker Tov.
Boker
Boker
Tov.
Tov.
Yeah.
Good evening
It's
for us. Yeah.
Good morning for everyone. I just want to say a few other words about Eyal. He is like a brother to me. It's so amazing. I mean, we've been like at the leading craniofacial hospital in Shanghai, or we've set up lectures in Vietnam, which are going to produce 5 years later incredible result where 10,000 school children have been screened, and 5,000 babies have been screened for myofunctional disorders and followed up with this great research project. And it's first going to come out in March, and we're so excited to tell you more to share about it.
The way this will work is Eyal will give the presentation. I'm going to be facilitating questions at the end. And I know we have people who are from around the world. So of course, if you want to say hello from where you are, that's great too. And so now Eyal, go for it. Thank you.
Okay. I see we have a lot of participants in this meeting today, and it's really a big pleasure. The fact that you asked me if I can present something really came in a very good time, because I've prepared this lecture for the Israeli ENT. They started a pediatric society, ENT society in Israel, and they asked me to present that. However, it's been postponed for so many times due to the COVID, and now I think it was postponed to May, and I'm going to present, well, the same presentation. Maybe following this presentation, I'll get some tips and ideas how to improve it, so we can get on board some of the ENTs, because after all this, presenting it here is like preaching to the choir. You are all on board, and we need to get those ENTs out there to open their eyes. So please feel free to help me improve this presentation, especially now that 2 days ago they started a new debate in the Israeli Pediatric Society, where they are starting to defame us, I mean the people that are looking and seeing that there are tongue ties everywhere, and the whole attitude towards, well, they're doing it to gain money rather than looking at the health issues. So I would love to share my screen and start the presentation. And I won't be able to look for the questions, so Samantha, please help me. Maybe
No problem. I'm right here.
Okay.
Yeah.
So remember, this is a lecture for a pediatric ENT in Israel. I think we have, like I said, they started a new society, and most of them think they know something about tongue ties. Most probably they don't really understand it as I see it. And my goal is to educate. So what should a pediatric ENT know about tongue tie? And if you don't understand anything with my special Hebrew accent, please also feel free to make me repeat it in the same accent.
Okay.
Okay. So because this is scheduled to be 45 minutes, the lecture for the ENTs, and there are so many issues we can't go through, I asked them first to take a photocopy or print the screen with these topics. So at their spare time, they can go and look into it. And I put Bobby Gehari's website because Bobby is an ENT. And if you are an ENT, you want to hear other ENTs. And also to introduce I'm sure they have no idea about myofunctional therapy or other topics. So I asked them, please take a photocopy of this slide and look at the topics at your spare time. And also let them know that there are books to look into about tongue tie. The first one is here by Carmen Fernando from the 90s. And this one by Alison Hazelbaker from 2010. And there are some more books about tongue ties and more coming out. I know there is a book now by Yasuhito in Japanese. And in Israel, it just came out this book by Orna Adriansen, which is called Lama Af, or Nose, about the nose, where she talks about nasal breathing and educating, something that the ENTs should really, again, understand the meaning of it and the importance of it. And I'll start with a disclosure. I'm the co-founder of BM Medical, and we're the inventors of the LiPer device. Mark mentioned it. This is a tool for tongue exercises, tongue training. And I treat patients with tongue ties with and without sternotomies for fee-for-service in my private office, and I'm the salary director of pediatric dentistry at the Tel Aviv Medical Center. And in 2019, we opened a multidisciplinary tongue tie research center, and it's also treatment for newborns at the Tel Aviv Medical Center, and I do hope to expand it to other ages. And as Mark said, I'm about, within 2 months from now, I'm reducing my clinical activity in pediatric dentistry, and I'm going to start doing research there because we are sitting on a gold mine of babies with tongue ties, and with the support of lactation consultants and body workers all together in the same room, we can do some research, especially when we are so close to the pediatric hospital. So wish me luck. And how did I get into this field? So I graduated dental school at the year 1990 in Jerusalem at Hadassah. I then spent a year at the plastic surgery department of NYU with cleft patients doing NAM. NAM is a technique called nasal alveolar molding, where you take a child, a newborn with a cleft lip and palate, and you mold the misaligned parts of his cleft, and you create tissues and you align them so the surgeon can have a better work. For example, in this child, what we do is we stretch, we create a columella. This little 5 millimeters tissue is so important. It's so important in the surgery of tongue tie. In the surgery of cleft lip and palate. So these are the molding plates that we are using, and we treat neonates. So it was very easy for me to go into the field of tongue tie in neonates. When I came back to Israel, I started the pediatric dentistry clinic at the Tel Aviv Medical Center. And then we started research on tongue tie in the year 2000. And it all started from a lactation consultant that said, well, you treat the babies with a cleft, why don't you release their tongues so they can breastfeed better? And I said, what nonsense are you talking about? Because I've never heard about it or never learned that it has anything to do with breastfeeding. And like I said, the year 2000, we started research. And then in the year 2002, my youngest daughter was born. And of course, she has a tongue tie, and she had also severe breastfeeding issues. And I was in the middle of one of our studies, our first study, and I saw how I can help the other mothers. I decided I'm going to try it on my own daughter. I released her tongue, and she breastfed beautifully after that. So I'm kind of emotionally involved with that because I know how much stress it can cause the mom, and I know how we can relive their lives of the mother, the child, and the rest of the family when everything goes well with breastfeeding. So in the year 2000, I was thinking that tongue tie and breastfeeding is nonsense, labial frenotomy only for orthodontic reasons, sleep disorders in children doesn't even exist, breathing, posture, ear infections, malposition of teeth, attention deficit syndrome, bedwetting, everything is kind of a predestination. If a child has it, what can we do? We treat the symptom. And today, well, I get smarter and smarter every day. And today I know that everything is connected. And the first sign of oral dysfunction is breastfeeding difficulty. And now I'm going to present it, as I said, for ENTs, and I want to ask them to make a small survey during the lecture. How many of you think that tongue tie causes breastfeeding or feeding difficulties? And I don't know what's the percentage today is going to happen, but actually this question started our research on cleft lip and on tongue ties. I'm sorry, I keep getting notes popping into my window, so I don't see all my slide. So I want to know what's the percentage of ENTs, pediatric ENTs in Israel now think that tongue tie has anything to do with breastfeeding difficulties. But it was done in the year 2000, where they found that 70% of otolaryngologists indicates that in their experience, ankyloglossia rarely or never causes any feeding difficulties. This is the graph. It was shown that the pediatricians are even worse. They're about 90% of them think that there is no connection between tongue tie and feeding. And it's still there today. And as I said, it just started a new debate in the Israeli pediatrician community about tongue tie release. And we have a lot of things to educate. Now, the next question I want to ask them is, how many of you think that the tongue affects the orofacial development? And we all know that the tongue tie can cause a narrow palate, that ankyloglossia is causing a narrow and long maxillary arch. The work by Audrey Surzagi-Gimino from Stanford. But before I start, I always like to have these things in my lectures for people to keep in mind about function. And function is affected by the form, and the form is affected by the function. And I show this video fluoroscopy, which is an X-ray video of a child being fed by a bottle. It was done in 1958. And if you can see, this is the bottle with the radio-opaque material, and this is the profile of the child that is being fed. And you can see how the radio-opaque material is being swallowed and goes into the esophagus of the child. You can look and get an impression of the size of the bolus that is being fed. And the only movement that this child should do is kind of make a vacuum in his mouth and press on the nipple to get the milk pouring down into his throat. And then Adrian did a very important thing when he used breastfeeding. And you can see here that the tongue movement is totally different. You can try to understand how the peristaltic-like movement of the tongue is moving. And look at the size of the bowls here. Just a small amount of food is being drawn or pushed into the throat and into the esophagus. It's a totally different way of feeding. Like you would say, this one is being fed by an NG tube. The other one, the first one, with a huge flux of food pouring into his mouth. So let's talk about the tongue. The tongue is an accessory organ of importance in deglutition, mastication, and speech. It also exerts influence. It affects the dental arch, the growth of, and the facial form. And these are all types of different types of a tongue tie. And the tongue position in the oral cavity, the tongue shapes the palate and the oral cavity. The teeth will be positioned at the neutral zone, where the forces of the tongue from the inside and the lips and the cheeks on the outside will balance. So the whole oral habits will change the balance of these forces, like mouth breathing, thumb sucking, pacifier. And when we see someone whose teeth are not aligned, you know that there is a misbalance between the forces from the inside to the outside. And this is a nice example I got it from Irene Markizan, about how the palate is shaped by the movement of the tongue. So where should the tongue be? It should be pressed at the palate. And if you can see at this illustration, you can see that there is a posterior crossbite where the upper teeth are being on the inner part of the lower teeth, where they should be on the outer side. This is called crossbite, posterior crossbite. And here, when the palate is supported by the tongue, you get a wide palate and a wide arch and a proper function. And when you have a wide palate, you have a wide airway, nasal airway, because up here is the nose. And this is a nice illustration from Brian Palmer's website. And as I wrote in the first slide, it was said that his website, which is brianpalmer.dds.com, is going to be taken off the web soon. So please feel you should go in and look at the treasure that is in there. So if we have this illustration that shows that with proper support from the tongue, we get wide palate, and where the support is not so good and the tongue doesn't sit all the way up, you get pressure from the outside, and the tongue and the palate is narrower, and we have the crossbite. I want to share with you a nice thought from Ray Fuller, where he says, hey, sometimes when we look at the oral cavity and we see a bump in the palate, something like that, what is it? And for years, I didn't quite understand what is this ridge. And Ray kind of opened my eyes. He said, well, most probably it is the vomer, the bone of the nasal septum, which is penetrating into the oral cavity. And now we have this narrow palate and most probably a deviation of the septum. Now, this is not similar to those bumps in the palate. These are other origin. This is tori. And you can read about it at the Brian Palmer website. So whenever you see a palate which is narrow and you see this ridge, you can tell this guy has a very narrow airway as well. So where should the tongue be rested, and what are the symptoms if it's not resting on the right position, in the right place? The ideal one is when it rests at the palate and we have a wide, something like 42 millimeters, and we'll get an ideal palate, ideal occlusion, you may say. When you get When the tongue is not supporting all the way up, we will have some kind of a crowded teeth, especially a crowded wisdom teeth. And we know that so many young adults are having their wisdom teeth taken out. When the tongue is a little bit lower, you'll see all types of crowding, either it's an upper or lower arch crowding. When the tongue is being beaten by the teeth, we know that we'll have all different kinds of malocclusions. And when the tongue is all the way down, we can see class 3 relations, meaning the lower jaw will be protruded forward. And it's very easy for the ENT to ask the patient to open their mouth, stick out your tongue, and if you see the scallop tongue, you know, hey, this tongue is not resting at the right position. Something is not working well here. A very easy way to evaluate the size of the palate is, well, if you're a dentist, we have the cotton rolls, and they are 38 millimeters, and you know, we just mentioned that the wide palate is, or a proper palate is about 42 millimeters. Then you can get a good idea whether this palate is narrow or wide. And we measure it between the first permanent molars, the 6-year molars between their palatal cusps. So the commutation of the frenotomy there is from China about even 1,000 years BC. And in the Middle Ages in France, a frenotomy was done by the midwife's fingernail. And until the mid-50s, it was kind of a routine assessment and even treatment in the US for a child to be born, and maybe even in the delivery room, they would release his tongue. And this routine frenotomy was stopped in the 50s, probably due to technique complications, sterilization, you can remember, an alternative, meaning the formula. The formula age, and then in fact, the tongue tie and breastfeeding are connected. Now there is a comeback of the breastfeeding since the 80s, the early 80s started. I would say that about 74% of the parents, of the mothers, did not try. 75% of mothers did not try to breastfeed their children when they were born in the 70s, and then in the 80s it started. The comeback of breastfeeding is there, and the pendulum is shifting, and you can see it also that there is a lot of research now. A lot of new research is coming up, and I think one of the heights of this thing, and Mark has a lot of his hands into this achievement, that the Frenulum Inspection law in Brazil, where every child should be examined. And it was now, I can see it 7 years ago, Mark. It's a long time. And I was wishing that other countries would have adopted it by now. So as I said, there is a controversy about it. This was published by the article of Messner and Lalkia in 2000. They examined the opinion of the 3 different professions. One was the pediatricians, and as I said, 90% of them said that tongue tie does not cause any feeding issues. I mentioned before the ENTs, that 70% of them said that it does not connect to breastfeeding issues. And on the other hand, there were the lactation consultants, and they said, well, 66 and 33% said that tongue tie does cause feeding issues. So we have 2 different communities. Each one is looking at the other community as they are crazy or fanatic, and there is not much communication. Now, this was in the year 2000. Today, I think it's much better, the percentages here. And you can, if you do the Google Trends, and you can see that the tongue tie search started to rise after the year 2010. What happened there? And another thing you can see on this graph is the amount of literature that is being published. So it was in the year 2010, we had 220 scientific articles. And today we have 707 scientific articles. There are a lot more scientific data on the subject. And what happened in the year 2000? Because it's kind of a young field, and now we are 12 years after. So in the year 2009, we established the IATP, and no ENTs were there. IATP stands for International Affiliation of Tongue-Tied Professionals, meaning it can be any professional from any profession that is feeling is interested and can contribute or help. And the professionals there are pediatricians, dentists, speech pathologists, lactation consultants, professionals from many professions. And someone said, maybe we'll say the teeth in the IATP instead of saying a tongue tie, we'll call it a tethered oral tissues. And today we are referring to other tethered tissues in the mouth. Another organization that was established is the ICAP. And this is the Tangtai Summit in the year 2009, where Alison Hazelbaker, here, a lactation consultant, gathered everyone who ever published an article about tongue tie to a room. And we had Edith Kernerman, who is a lactation consultant, David Todd is a pediatrician, Sandra Holtzman is a speech pathologist, Mervyn Griffith is a pediatric surgeon from England, Kathy Jenna is a lactation consultant from the US, Betty Coriolis, rest in peace, is a pediatric surgeon, Uri Fura from Israel, Larry Kotlow, and other very distinguished people. And we all sat there and said, hey, we see the same things, we never learned about it. And our experience led us to sit together and talk. And you could see the soar in the understanding of tongue tie following that meeting. The first thing the IATP started doing was creating a definition. And the definition that was created by a very good professionals, or the best professionals that could join together forces, are the definition is persistent lingual frenum is an embryologic remnant of tissue in the midline between the undersurface of the tongue and the floor of the mouth. And a tongue tie is a restriction of normal tongue movement in the presence of persistent lingual frenum tissue. And today we know that the best definition that we could come up with is a very, very bad definition. And today we start to get new definitions. For example, everybody has a tissue under the tongue. Everybody has a frenum. And what is normal tongue movements? There are so many questions in this definition that nothing is clear out of it. So people are starting to get or to look for other definitions. For example, tongue tie, we said it's a restriction, a restricted function because of the persistent lingual frenum. But what about the subfunctional tongue that can be caused by other factors, not only the lingual frenum? It can be caused by a high palate or neurological issues or muscular issues. So let's call it a subfunctional oral system or an oral dysfunction. And not only the tongue is the issue, it's the oral system. And when you ask what's the prevalence of a tongue tie, or people would say up to 10, 13%. And there are at least two articles. One of them from Irene Marquezan and the group in Brazil, where they are talking about 34.6% of an altered tongue. And another work from 2020 in Spain. And they are talking about, like I say here, we found the prevalence of neonatal ankyloglossia of 46.3, of which 70% were symptomatic. And therefore, it's a 32.5% of the newborns born in a hospital in Barcelona. So it's a huge percentage. And when you try to function with oral dysfunction, it is like walking on a tightrope. You can do a distance, but it's full of compensations, and it's very difficult to function properly for the rest of your life, and you always compensate. When we look at the newborn and we look at the shape of the palate, if you remember, it should follow the shape of the tongue. Remember, this is the way the tongue is shaping the palate. And when a child is born and his palate is shaped like the tongue, everything is good. But what happens when the child is born and he has a very high palate, like the bubble palate here? When we put them one against the other, look at this high palate. When the child was swallowing the amniotic fluid, it couldn't mold the palate to the right shape. And when this child here on the right is trying to breastfeed, where will the nipple be? How much air will he swallow? Maybe he will bite with his gums in order to maintain the breast at the right position. Or how soon will they transfer into bottle feeding? So on day 2, not everyone is equal. And having a high palate is very common with a tongue tie. As we say, tongue tie equals a narrow palate and a high palate. And the thing is, when this work was published, the bottom line was that these findings suggest that variation in tongue mobility may affect maxillofacial development. And I don't think even a single ENT has paid attention to it in Israel. Another thing that was published in a pediatric dentistry journal, that there is a relationship between acute otitis media and the anatomic form of the hard palate. We have the Eustachian tube that goes from the ear to the palate, and we have a high palate. It is very, very flat. There is no spontaneous drainage of it. And when it is very flat, you have a wider angle. And the bottom line of this article was there is a positive correlation exists between the presence of acute otitis media and high palate. And their understanding was that we had the hypothesized that palatal shape in the neonate should be used to alert the pediatrician of a child predisposition to acute otitis media. And they didn't mention the fact that, hey, why don't you look for the reason for this high palate to happen, and let's try and correct it. And another thing by Gimino and his group about the fact that short lingual frenum is connected to obstructive sleep apnea. And again, they said short lingual frenum may lead to abnormal orofacial growth early in life, which is a risk factor for the development of sleep disordered breathing. And they suggest careful surveillance of abnormal breathing during sleep if you have a short lingual frenum. Nobody suggested here, hey, go ahead and take care of this tongue tie so the development of the child will be on a better track rather than where he's heading for today. And Gimino also published the fact that there are missing teeth and are predisposing, it's a predisposition for obstructive sleep apnea because their palate is smaller. Our children with permanent teeth missing due to congenital agenesis and a permanent teeth extraction had a smaller oral cavity, also known to predispose the collapse of the upper airway during sleep. So we understand now that the size of the palate is actually the size of the airway. And this is something I think the ENTs should get into their understanding, whenever they treat a child with signs of narrow airway, they should think about the first reason that started it and look for the tongue tie. And here are samples of high narrow palates. Very high, very narrow. And as we said, there is a connection between the form and function. And I want to show here a case where there is no tongue, just a remnant of tissue. And look at the size of the lower jaw. Nothing was there to push and expand the lower jaw. So form affects function, and therefore function is being affected by the form. And I want to show you now a vicious cascade that may happen if somebody has some kind of a malfunction, like a tongue tie. It doesn't happen always, but it's a cascade that may happen, and those kids are on our list of patients during the day. So if we have a tongue tie, there is improper swallowing of the amniotic fluid, there is impaired breastfeeding, and they switch to bottle feeding. Those kids will have high narrow palate, and they will have mouth breathing. And each one of these affect the other. It's kind of a vicious circle that one affects the other. Now, being with a mouth breather and a high narrow palate, it can cause stereocytitis media, lead to sleep disordered breathing, and occlusal problems. So imagine a child with an ear infection. He doesn't really sleep well. He has impaired hearing. He feels pain during the night, so he wakes up to school. He's not that alert. And above that, he has also sleep issues. He's snoring and maybe even sleep apnea. And this child will show learning problems like ADHD-like symptoms and more. A child that is a mouth breather will show us a violent oral flora, and this may cause more cavities and more periodontal disease. And if you're a dentist, you are very well familiar with that. But all this area here on the left is totally obscured for dentists. And until we get this understanding into the curricula of the pediatric of dentistry and of medicine, we still have a lot of things to educate. And these very, very extreme faces, which are the adenoid faces, and the ENT, they see them. They will never look for the problem. They will go and do the surgery, and that's it. Nobody will follow up if they change their habits and started breathing through their mouth, through their noses. And here's an example of a guy with a high narrow palate. He has a lot of functional issues that are associated. He has asthma, rhinitis, allergy. He had 2 nasal and sinus surgeries, hardly sleeps, hardly feels any taste, has breathing issues, headaches, eye pressure, eye swelling. All to the bottom line is that he has a very poor life quality. And at this state, it's not just releasing the tongue and helping him, because if you release the tongue, you may even increase the chances of his breathing issues, because the tongue cannot sit on the palate. His tongue will not be able to sit on the palate. So he needs to undergo a thorough treatment with expansion. And I wish we could see him at the age of a few days. Let's talk a little bit about posture. We know today that there is a change in the posture of people, of the patients, after they undergo a frenotomy. And this work was done by Giovanni Olivi. And you can see the patients, how his posture has improved, most probably because he can get to breathe better. And we see that every day. I want to talk a little bit now about the classification, the diagnosis, but maybe we can do a short stop here and listen to if we have some questions so far.
Well, there have been some questions regarding acid reflux, and Leslie had asked, do you believe acid reflux in babies is caused by tongue tie? And parents ask her, pediatricians just prescribe medication, and the infants and the parents have started researching.
Okay, so about acid reflux, the question is whether it's a real reflux or is it aerophagia, where the child is swallowing a lot of air. If you remember the high palate, the child that has such a high palate will necessarily swallow a lot of air. And when you swallow a lot of air, you get signs of which are very similar to reflux. And there have been, I think, 4 articles so far, but 2 of them last year, one of them by Giovanni Olivi and Philip Hand, show that there was a significant improvement in gastroesophageal symptoms following the frenotomy of the tongue and the lip. I think it is more scientifically validated than just prescribing PPI, anti-reflux science, because there is no scientifically approved practice. They call it green apple. Pediatricians do prescribe drugs for reflux, and sometimes they help, sometimes they don't. And we also know about the side effects of those drugs, which are causing more of issues with the calcium in the blood and more fracture susceptibility of those children. I don't say every reflux patient has a tongue tie, but it's an option to understand. And this is one of the research projects that we are intending to do with our pediatric gastro department.
Yes, and do you want me to ask some more questions that came in, or?
Let's do another one and then we'll go on.
Okay, with regard to the palate being wide, what age are you referring to? By what age is the infant's palate expected to widen and flatten?
Oh, that's one of the the million-dollar questions. We see newborns with a wide palate and we see newborns with a very high, narrow palate. And the question is, if we release the tongue, will it be, if we compare 2 populations, one that we release the tongue or made them breastfeed better and compare them at the age of 6 months and see whether the palate is wider on one population or on the other. Today, what we know is that a breastfed child has less orthodontic issues and less sleep apnea, I think. So we know that breastfeeding is kind of a supporting technique to prevent malocclusions. But I don't know of any research that has examined this question. And once again, another thing in our topics to look for.
That's great.
Okay, let's continue. So now we are talking about the classification and diagnosis of a tongue tie. There are several different classifications, which, and this is, I think, one of the reasons why the subject is so controversial. Everybody sees something else. So about the anatomical classification, we have 2 major classifications that are being used. One of them is the Kotlow Classification, where it starts from 1 to 4, going from the 4 is the worst, and meaning the frenum is all the way to the tip of the tongue, and the Coriolis Classification, which is different. The tip of the tongue, type 1, is connected. And actually, they are saying the same things, but with Kotlow, you need to measure the tongue, and it's almost impossible to measure the tongue in a newborn. So most of the people dealing with newborns are using the Coriolis Classification, and it's more like that, where the tie is. This is a model created by Betty Coriolis. So in her honor, I'm enjoying to use it. So type 1 is all the way to the tip. Type 2 is a little bit behind. Type 3 is in the middle of the tongue. And type 4 is way back there, maybe submucous one or behind the mucus. Some examples, type 1 all the way to the tip. And you can see that it can cause a diastema, a lower diastema. You can see how it sticks out his tongue and folds in the lower lip. Here you can see the type 1, the anterior one is also part of the posterior one. This very, very famous heart shape of the tongue. And this is my older daughter that was breastfed beautifully, speaks beautifully, everything is functioning well. But you can see when she sticks out her tongue, she sticks out the whole lower jaw with it. And a type 3, it's in the middle of the tongue. You can see several signs of malfunction here. We call this the Eiffel Tower, with a wide base at the alveolar bone. And here, the porch of the Eiffel Tower is where the salivary glands are meeting. And the type 4, when you look, there is no frenum at all. And when you touch it and you palpate, you can feel the rigidity of this tissue. Now, I wouldn't say that every type 4 should be snipped or revised or have the surgery on it, but just acknowledge the fact that there is a tissue and something is wrong, because even though it looks perfect, and the ENTs always ask the patient or make the diagnosis by, can he stick his tongue beyond his lower lip? Well, everyone can stick their tongue beyond their lower lip. You can put your lip inside, this is not the question. So here we have a lot of symptoms with that newborn, and this is a very, very wide frenum, meaning tissue here, which is the mucosa and the fascia, and sometimes even muscle, the genioglossus muscle are there. And if you do some kind of a body work, you may be able to, and tongue training, you may be able to avoid surgery, or sometimes you need to combine surgery with it as well. So this was an anatomical classification. Now we are talking about the functional classification. And the first one was the Hazelbaker ATLFF. It's a tool where you get a number at the end of it, and it's mostly by the functionality of the tongue. And now we have the Surzagi's and Audrey Yoon's TRMR, tongue range of motion ratio. And there are two tongue range of motion ratios. One, the tongue tip to the incisors, and the other one is the tongue tip to the middle of the tongue, the middle of the tongue to the palate. And here, this slide from their article, you measure the maximal opening, and then ask the patient to lift the tongue to the spot, which is the incisive papilla. And this is, you get the measure now. And the other option is to do the suck, get the middle of the tongue pressed against the palate and measure the distance between the teeth at this time. And you calculate the TRMR. And if you get a range which is from the tongue tip above 50%, then you are in the normal range. And if you do on the middle of the posterior tongue mobility, which is, you need to have more than 30% distance between the teeth. And this is a tool in order to understand the movements and see if the treatment works. And sometimes we see patients that are being advancing from one level here to the other. It's all about training, stretching, strengthening. And these are examples from their article about this type and the measurements. And when you have this adult with a very, very severely restricted tongue. And now we have anatomical and functional classification. And I would say that the Martinelli tool combines it all, and we use it a lot in the pediatric tongue-tie clinic. We have the function, which is the breathing issues and the crying. And then we use also the shape of the tongue, the shape of the frenum, the attachment, the insertion, and the origin. And I would say that the most useful one for an ENT is the combination of both all the anatomical, the functional, and the symptoms. We should ask for the symptoms. And I like this article that was published by Richard Baxter in March 2021. And they mixed and added a tool or a questionnaire. They call it the tongue restriction questionnaire. And you have questions from different functions about communication, speech, feeding, grinding teeth, sleeping, snoring, all these check marks, and you start to ask. And once you ask, you get to know if there are symptoms. And then they ask how much does it interfere with their quality of life. And you add to that the anatomical grading, or what do we see from the anatomical point of view, and decide at the end whether to go ahead and do any kind of intervention or not. So I wish an ENT that is seeing a patient for ear infections or enlarged adenoids will consider looking for that, and maybe during his surgery for correcting the sleep apnea, he will look at the tongue and release it at the same time. And of course, before and after, make sure that this child is getting myofunctional therapy. And there is another thing that has been developed, another tool that may help ENTs. They call it the Functional Airway Evaluation Screening Tool. And they took several things that can add to the ENT to understand whether this child has a higher sleep disorders. Is it prone for sleep disorders? And the things are mouth breathing, and this is a functional issue. Mental strain. When they look at the patient, you look at the child, you look at the patient, you see if they try to close their mouth, how much strain is there in their mentalis muscle. Look at the tonsillar hypertrophy, tongue tie, ankyloglossia, whether they have dental wear, because we know now that people are grinding their teeth once they have sleep issues and breathing issues, and of course the narrow palate. And now, when we find that there is an oral dysfunction, what do we do? So we have several solutions. If it's the structural origin, then surgery is indicated. Either it's frenotomy or frenectomy, whether it's TNA, orthognathic surgery, or even orthodontic treatment, a palatal expansion, mandibular advancement. If it's a functional origin, myofunctional therapy, here you go in, hey. And most likely, it is a team approach because everything is combined. And then we need to have a team. And when we have a team, who is leading the team? On a newborn, the team is led by the lactation consultant, that's for sure. Sometimes we should have a pediatricians. Unfortunately, now some of them are not really helping, rather they are interfering with the diagnosis and the treatment. A body worker is very important, either physiotherapist, occupational therapist, osteopath, craniosacral. So far, we don't have yet myofunctional therapy for newborns. And then the last is the surgeon. And it's not that he's doing the surgery and everything is fine. No, we need to keep on working with the body worker, with the lactation consultant. On older ages, the team is consisted of, the team leader is the speech pathologist or the myofunctional therapist. And the team is either the ENT, the orthodontist, the pediatric dentist. The issues are feeding, breathing issues, and malocclusion. And again, we need the body worker, and sometimes it's the myofunctional therapist that is doing all this work, and surgery if there is no other option. And in children and older patients, when we have breathing issues, sleep, malocclusion, and posture, again, it is the myofunctional therapist who is the team leader, and then the doctors or the rest of the team are doctors, sleep specialists, again, body workers, and the last one is the surgeon. And I'm sure the ENTs in Israel don't really know what myofunctional therapy is. So here I am trying to explain what myofunctional therapy or oral myology was known. And it's please let me know if I'm correct. Myofunctional therapy uses combination of physical therapy, exercises to improve the bite, breathing, and facial posture of those with orofacial myofunctional disorders. The training targets the face, the neck, the mouth, soft tissue to reach optimal tongue position, and we discussed the optimal tongue position and the oral rest position. The OMD can affect people of all ages, and the treatment is customized based on the age and the symptoms and the patient himself. Now, to my understanding, there is no formal education. There is not a unanimous way. I know that the AMOT is doing a great job, and we're looking forward to your next course in Israel. People that can do that are speech language pathologists, physiotherapists, occupational therapists, dental hygienists, physicians, and dentists. And it was shown that myofunctional therapy is reducing sleep disordered breathing in 50% of the patients. I know that in children it's more. And here I quote for the ENTs the article about that from 2021. And what's the bottom of this whole issue? When we decide that we need an intervention, and I love this show that the tongue is being the muscles of the tongue. And this is a protocol that I follow. I don't do on any child other than after newborn, but any child with myofunctional disorders. I insist of having a myofunctional therapy first, at least a month before, and then for a period after that, and I do the surgery. Like we say, tongue training and early tongue training is a lifetime benefit. And this is something that was shown to me by a Yemenite family, that the grandmothers were doing all kinds of manipulation. Maybe it's more of an osteopath issue, but they were doing all kinds of manipulation on a newborn in order to make them breastfeed better and function better. As we know that the Indians would close the newborn's mouths in order for them to be nasal breathers. Also, the Yemenites in Israel had a lot of, let's say, traditional medicine that really worked. So now about the tongue training tools, we have the Liper device. There are all kinds of other tools in order to make the tongue function better. And we know that if we are having a patient that had a surgery for obstructive sleep apnea, and in this article, they showed that those who improved their mouth breathing following adenotonsillectomy, because nobody's following them in Israel. Nobody's having any follow-up following the surgery. But if you insist in getting them to have myofunctional therapy, they show that those that improved their mouth breathing had better sleep, had better behavior, and better life quality. And I'll talk a little bit about the LiPR device, which was specially designed to fit under the tongue. It's a perfect combination of flexibility and softness, and also hardness, biocompatible materials, and it doesn't slip under the tongue. Some physicians are using it in order to examine better, and you use a flashlight that fits right in there and leads the light under the tongue. The LiPR can replace the fingers for home exercises to lift the tongue, stretch the soft tissues, and train the tongue and brain for better function in neonates and older patients. When I say stretch the tissue, it's a whole issue, and it's an opening for a full lecture if we add the Nikki Mills work and Irene Marquezan, whether this tissue can be stretched or not. But as I showed you with the cleft lip and palate patients that I am doing the nasal alveolar molding, where we stretch the tissues, we actually create a tissue from nothing. There is a lot of cases, there are many cases that can be stretched. And when I showed you the type 4, and sometimes we just need to do the tongue training and stretching the tissues, and we can escape the surgery. And here's a video of a mother using the LiPR on a child. I hope you can see that. And the mothers can use it and do the tongue training. And here the parents can do it for older children, or people can do it for themselves. And usually I ask them to do it before surgery, and if surgery is indicated, then after surgery as well. And this is the take-home messages for the ENTs. Your patient is a functional failure. If somebody gets to the ENT, there is some kind of functional failure. Either they have recurrent ear infections, feeding issues, breathing issues, tongue posture. Something can be fixed, and something led them to become an ENT patient. And they should always look for a tongue tie in every patient, and they should try to evaluate it before surgery. Another thing is they should consider the release in every surgical patient. And then if they do a surgery without myofunctional therapy before, I rather they did a frenectomy with sutures rather than frenotomy. It was shown by several articles that frenectomies are more efficient with the sutures in older patients. And then each patient should receive myofunctional therapy before and after surgery. Make sure that there are nose breathers and the tongue posture is correct. Just a second. Now I want to show you 2 cases, and we are ending with that. And I want to make you hear. Let's see if I can share the sounds. Let me know if you hear it, okay? And this is a case of a 40-year-old man that was just before surgery on his vocal cords because of hoarseness. And it was for 20 years he had this hoarseness. And now before surgery, he started working with the speech pathologist. And this is what happened immediately following the surgery. So try to understand, it's in Hebrew. Let me know if you hear it.
ניתן למצוא אותו.
וניתן למצוא אותו.
כמעט בכל מאכל.
כמעט בכל מאכל.
מהמבורגר ועד לסלט.
מהמבורגר ועד לסלט.
So this was the before, and here is the after.
רוטב אלף רעים, הוא רוטב אותו מכינים עם מיונז, קטשופ ומגוון ירקות חתוכים. הרוטב יכול להאכיל בצלים, מלפפונים חמוצים, פלפלים, זיתים וביצה.
הרוטב נפוץ מאוד.
הרוטב נפוץ מאוד.
ברשתות המזון.
Did you hear it? Samantha?
Definitely. Oh, we heard it. That's fascinating.
Okay, so and this guy, he tells me, and it was stable for more than 2 years. I contacted him not long ago. He said that following the surgery, he called his friends from the army 20 years ago, and they couldn't recognize his voice. They didn't know who he was. And it's
Wow.
kind of a miracle. And now I want to show you another case. It reminds me what Katrina showed last week. And everything is related to this video fluoroscopy about this child. It was 1 year old when I saw him. The mother was exhausted, kind of broken down, so sad. And I will show you later. I will read what she wrote to me. And it really brings tears to my eyes. Look at this video fluoroscopy. This is a test, a swallowing function test, or
Remarkable.
okay, look at it. Now it took the first bite. The first one went down, and look at the food is there. It's live. It's real time. The food doesn't go down. It goes up and down, goes up and down, and it stays there for about 45 seconds. And this is how the mother was feeding the baby since he was about a month old, more than a year. The food doesn't go down. And if you can look carefully, this area doesn't lift. The posterior area of the tongue just doesn't lift. The bolus is not being sent down. So the mother came to me after she went through all the great doctors and great lactation consultants, great feeding specialists in Israel. And we did it was a tongue tie. We did a revision, and immediately at the waiting room, when she was waiting, she starts shouting, "Hey, he's starting to eat a cracker," for the first time ever. So I want to read it out to you. It's a bit long, but it's so important. Now I didn't edit, so you can feel the pain between the lines. And now Ari was born. I can't see the first line because it is being.
We see it. We see it though. We see
You
it.
can see it.
Yeah.
So I can't read it. I don't remember.
I can read it. Ari
Okay.
was born May 15th, 2020 in a normal childbirth and normal pregnancy. At the age of 1.5 months, after breaking down percentiles, I was offered to stop breastfeeding and I switched to formula. And at 4 months, when he started tasting a spoon, it seemed that his swallowing was not optimal, but he ate and grew. When he started solids, however, he began to emit in huge quantities. And not only did he gain weight, he actually lost weight and dropped to a very low percentile. Along with the vomiting, he began regurgitating, ruminating while eating and between meals. As a result, we reached our pediatrician, who referred us to a specialist, a gastroenterologist, who said that it was a behavioral and that I needed to change attitudes toward him. Sorry, I'm fine. 1 second, I need to mute. There you go. I needed to change attitudes toward him and recommended and introduced me to the term rumination and recommended that we go to a gastro clinic in Ichilov. We arrived at the gastro clinic and met a Dr. A, who assumed there was a problem with the pylorus and therefore the chronic vomiting or reflux. He also addressed the fact that Ari looked different and checked to see if he looked physically like the rest of his brothers. And we got the feeling that there might be a problem with Ari. He then referred us to a speech therapist named Kay, who asked me to feed Ari and saw his difficulty swallowing and eating. While eating, he did ruminate, and she seemed to be shocked and suggested we end up in the eating disorder clinic. By the time our appointment arrived at the eating disorder clinic, we went for a second opinion with Dr. B, who thought he might have an allergy in the esophagus. And we got to Sheba Hospital, and Ari had a gastroendoscopy that came out normal, and all biopsies taken came out normal. And Dr. B referred Ari to a swallow test and tried to see what Ari had. We never bought her the test. We just didn't, because we kept looking for the answer. Plus, Dr. A suggested that we do gastro and swallowing function. So we came to Ichilov for the swallowing function test and saw that the first swallow was descending okay. And from the second swallow, the food was going up, and they stopped there and wrote down that Ari has a behavioral problem. It is important.
This is the video fluoroscopy you saw before, the one that took for 45 seconds for him to swallow a spoon.
It's important to note that we have always emphasized that his problems revolve around his food, around the food, although he did ruminate all day because apparently he was unable to swallow and got food stuck in the esophagus. But all the strange movements with the tongue and the strange swallowing, everything was done only while eating. So we came to our pediatrician, Professor E, and said that he spits up a lot and that it happens a lot at this age. But after 2 months, Ari was already 8 months old, that it did not go away, and insisted that something was wrong. And we showed him a video of Ari eating. He decided to send him to a neurologist, Dr. T. Once she saw the video, she referred us urgently the next day to Schneider for a neurologic examination at the clinic. We arrived the next day and met Dr. T, who claimed that Ari was perfectly normal and had no neurologic or developmental problem. Advance the slide. And referred us to Juliana, the occupational therapist. We came to Juliana and asked her opinion if Ari was autistic and had neurologic or mental problems, and ruled out and told us that Ari may have a tongue tie, and she seemed to have some weakness in the muscles and of the tongue or hypotonic tongue, and that we should train and exercise his tongue. And she asked to see the swallowing function test. I kept practicing at home with the food and nothing got better. So at some point we tried to go get answers from the ENT doctors. Our ENT doctor that we very much trust.
How do you know someone's bad?
Hold on. Our ENT doctor that we very much trust said that he didn't deal with it, but there might be someone else to help us. So we reached out to Dr. J, who said Ari seemed to have no hunger satisfaction mechanism, which is true, by the way, but not related to the subject, and gave him a test with a tube. It was a test with a nasal endoscopy. Checked the structure of the esophagus and said that the test came out normal, and referred us to Dr. H, who might be able to help. So we got to Dr. H, who said he was displacing the jaw, a new problem that we discovered in the basket of terms we had received, and it seemed to be something related to the oral cavity, and she wants to see the swallow function test. We brought the test to Schneider, and Juliana devotedly sat down with the best doctors on the test and suggested we might do it again in Schneider. Eyal, we might need to do the summary because we have to end.
The last thing. Okay, the bottom line was that it was the lactation, the speech pathologist that said, hey, this kid has a tongue tie. I released the tongue and immediately everything went away. And this mother, that you could see the pain in her writing, that she saw dozens of doctors and they told her that her son is autistic or something is wrong with him. Everything was a tongue tie, and everything got improved following this simple frenotomy. So it's just life-changing experience to get those patients that the mother struggled with, the parents struggled with them for a year. That's it.
Yeah, it's remarkable. And what I love is that we have so many people who are working in different disciplines around this. And here we're seeing the before and after with the frenotomy. And Eyal, this has been so wonderful, but I don't think we're done with this. There's a lot of questions, but there also are more people who I feel and we feel would be best served to answer specific areas of function. So what we've assembled for next weekend on Saturday is a panel of the some of the experts we have in our room here. And we're going to invite you all back around this topic. Kevin Boyd will be there. Katrina Rogers discussing the pediatric dysphagia element, Robin Glass as an occupational therapist, Silke Weber, ENT in Brazil. I think we need to continue the discussion, and also there's other questions that have been posed. So I would like to get those questions to you and then respond to them. Does anybody have any other aspect? If you do, if you want to hear more, and by the way, everyone wants to know when we can get this recording. They want their ENTs that they work with to see this. And I think that's really the point of it, is to not preach to the choir here, because I think we're all in the room. We believe in it. I know we have extended guests just for the reason of exposure of these thoughts and ideas, and there's many questions embedded. So we are going to continue this next Saturday at 8 a.m. Pacific time. I'll send out a notification. There'll be a registration. And yes, we'll have this open for all. And I've saved the chat so that I can get you some questions that have come in. Some people are looking from the dental perspective about expansion, the timing, etc.
We will also post a notice about this, about a means to share a recording of this presentation on our Facebook page. So if you click like on our Facebook page, you can get a passive acknowledgement and be able to share it with people. And on that post, we'll also encourage people to ask questions. So Academy of Orofacial Myofunctional Therapy. And so keep a lookout. We'll send out a notice to everyone on that Facebook page.
Do you want to say anything, Eyal?
I want to tell you that, as you can see, everybody, I was very excited to present it. I was thinking about the ENTs because hopefully, if I can transfer the message correctly, we'll have some more people on our side, rather than fight against them. Maybe let them join us. So please help me do that.
We will have an all-star panel that will wrestle directly with that question. And one of the panelists, Silke Weber, she's on our AMS board. She is an ENT sleep specialist and a professor and researcher, and she helps set policy for the European Respiratory Society. So, we have a way.
Yeah, I think
Is not long ago in France, the pediatrician's declaration was, I think, last week. This is what started the issues in Israel with the pediatricians, that Tangtai is over-treated. So,
yeah, I think the most important thing that I got out of this whole hour and a half or whatever is what you said, that what we're treating is the ENT failures. And to me, that really hit home, because I have an adult and child practice that have had many surgical procedures, and nobody looked at the tongue as a problem, as the cause. So thank you so much for this talk. This was amazing.
thank you, Joy. Thank you very much.
Thank you, everybody. We are going to sign off now, but to be continued. And thank you for everyone in the comments, for those who explained some different aspects. And we all have such a vibrant, dynamic community. It's just a wealth of resource and knowledge between us. So thank you again for being here today.
Thank you.
Okay, everybody.
Bye-bye.
Goodbye.
Thank you so much.